In the figure 1, PLR demonstrated a statistically significant predictive value for in-hospital mortality. In conclusion, the results of this study demonstrate clear and significant associations between the PLR and mortality, as well as between the CERA and the length of hospital stay in individuals diagnosed with aortic dissections. Thank you.
Thank you very much. Any question, any comment, please? Thank you, Dr. Vural. Second presentation. The value of rate of oxygenation shock and diastolic shock indices in COVID-19 patients. Dr. Sertaç Güler, please. Absent. Okay. Yok herhalde değil mi? Please, third presentation. İki yok. Efendim. Bakalım. Öyle değil mi? Bu o değil. Post-myocardial infarction is a rare complication. Ventricular septal rupture. Dr. Miraç Özcan. Tamam. O zaman şöyle bir tamam de iki şunlara eksi diyelim. Please, fourth presentation. Extracorporeal membrane oxygenation used to maintain tissue perfusion until harvesting in patient after brain death. Please. İsim efendim yok ama şey yok. Altı çizilmiş.
Hi everyone, my name is Mehmet Emre Akçay. Sorry for the interruption, but my professor, who is Mücahit Avcil, is COVID now. That's why I will present this presentation for him. How can I pass this slide? This one? So, I think you know what is ECMO therapy. ECMO therapy is a therapy if you had a lung infection or a heart malfunction. This device provides lungs, lung and the heart functions for you. That's why, and it's if you have a cardiopulmonary problem, we will put you on this device. So our case, who is a 48-year-old male who presents with syncope, no known disease or drugs, and the EMS services in our city recognize cardiac arrest and start CPR to the patient and take this patient to nearest hospital. And when we take these patients to our center, had and 40 minutes to CPR, and total 5 times defibrillation. In first physical examination, patient has a Glasgow Coma scale of 3 and 4 score of 0, 96 blood pressure and heart rate of 98. And the other, if this saturation is under intubation, of course. We make an CT angiography for intracranial arteries on the 3rd day, and the patient ruled for brain death. And we talk with other patient's family for organ donation, and the family accepted the organ donation. And we put this patient for critical care unit for follow-up. Of course, patient is hypotensive despite 3 of inotropes and the vasopressors. So we decided to put this patient on ECMO. On later diagnosis of this patient, urine analysis comes with amphetamine positive, and patient takes heparin, sedation, inotropes, and vasopressors. So you can see a picture of us here. We are putting ECMO to this patient, and in interaction, we are placing cannulas here. On the left side, you see Mücahit Avcil. And the donated organs on ECMO, liver, right kidney, heart, aorta, and iliac arteries, after 20 hours on cardiac arrest. So we are taking these patients to surgery room for extracting organs. So normally ECMO is a new therapy. The medical world is trying on it, so we think it is beneficial for using it. But I think it's the third one that we use for organ donation patients, and its ECMO's usage areas will be widened in the future. And this is on the surgery room. So we think ECMO device can be utilized to buy time for harvesting in a brain dead patients. And it is proved ECMO device can be beneficial for organ perfusion. Thank you for listening.
Thank you. Any question, any comment? Thank you. Please, 5th presentation. Post-myocardial infarction is a rare complication. Ventricular septal rupture. Dr. Miraç Özcan. Kaçıncıydı? Geldi bunlar. Üçüncü mü? O zaman üçüncü.
Thank you.
Değil mi? Sen? Var mı?
How do we use? Yeşil. So welcome again. Myocardial infarction is one of the leading causes of death in our country and in the world. As a result of the establishment of coronary care units and the development of the reperfusion methods, the mortality and complication rates due to MI have decreased considerably in recent years. Complications can be examined under the subheadings of ischemic, mechanical, arrhythmic, embolic, and inflammatory complications, such as pericarditis. The majority of MI-related deaths are the result of arrhythmic complications. However, although mechanical complications are much less common, they are more deadly. The most important ones are ventricular free wall rupture, ventricular septal rupture, and acute mitral insufficiency, and they often progress with cardiogenic shock and sudden death. Other mechanical complications include left ventricular aneurysm, ventricular pseudoaneurysm, cardiogenic shock due to severe left ventricular dysfunction, right ventricular failure, and dynamic left ventricular outflow tract obstruction. So in this case, an 85-year-old female patient was transferred to our emergency department after ST elevation was detected in the anterior and inferior leads in the EKG taking at the center where she applied, with complaints of typical chest and back pain. The patient's history was unremarkable except for hypertension and the medication she was using for this reason. In the physical examination of the patient, her general condition was fair, she was conscious, cooperative, oriented, her Glasgow Coma Scale was 15. Her vital signs were 90 to 60 millimeter, pulse was 95 beats per minute, respiratory rate was also 12 minutes per minute, temperature was normal, her saturation in room air was normal, no pathological findings were found in the system examinations except chest pain. In the EKG taken in our emergency department, there was ST elevation in the anterior and inferior leads, and bedside echo revealed her ejection fraction was 40%. Anterior and inferior were hypokinetic, or her also left atrium, so angiographic performed due to patient's current clinical picture revealed 100% LAD D2 level and 80% circumflex osteal obstruction, occlusion in the distal thin ends, and plaque in the RCA. Since there was no room in the coronary ICU, the patient was taken back to the emergency critical care unit in a stable condition and continued to be followed up. However, the patient who was hypotensive and unstable was consulted by the cardiovascular surgery clinic and was taken to ICU after ventricular septal was observed in the repeated echocardiography. This is a common situation in some of some ER departments around our country. These ICU beds are not enough for patients. Sometimes some post-op patients, post-coronary angiography patients will need it to take care in ER after their surgery. So they are not taking ICU treatment because ER is not like ICUs, but we are trying to do our best. But we are, for example, this patient was taken back to ER after her coronary angiography. So the patient was taken to intra-aortic balloon pump and inotropic aging was started. The patient arrested in the 3rd hour of the follow-up and was accepted as extus as she did not respond to the interventions. Discussion. Transthoracic echocardiography is used to determine mechanical complications caused by acute MI and has a sensitivity and specificity of nearly 100%. Especially with TTE, the location and the size of rupture, ventricular functions, and shunt degree can be determined. In this case, post-MI hypotension was detected and VSR was supported by bedside echo in terms of possible complications. Cardiac catheterization is also effective in conforming the diagnosis and measuring the shunt. Rupture localization can also be detected by left ventriculography. Aggressive medical methods and early surgical intervention are the basic approaches in providing hemodynamic stabilization in these patients. Intra-aortic balloon pump support, vasodilator agents, diuretics, and inotropic agents should be used to reduce left ventricular pressure and provide hemodynamic stabilization. However, since 24 of patients receiving medical treatment alone die within the first 3 days and 75 within first 3 weeks, early surgical interventions must be performed. However, despite surgical treatment, mortality increases up to 70%, especially in VSR that develops after inferior MI. Although coronary bypass performed with surgical repair does not affect in-hospital mortality, there is data that increases long-term survival. Although percutaneous closure is considered an alternative to surgery in patients with acute hemodynamic disorders, long-term data are needed. So these are the references. So I'd like to say a little few words about this again. These ICU bed insufficiencies are, as well as coronary ICU or normal ICU units, are a big pain for our performing our job. Any questions, any additions? Thanks.
Thank you, Dr. Özcan. Any question, any comment? Thank you. Next presentation.
This is my other presentation. I'd like to talk about a case with superior mesenteric artery dissection. Abdominal pain is one of the symptoms that constitute the majority of the reasons for admission to the emergency department, both acute and chronic. Abdominal pain, which occurs especially due to vascular pathologies of the intestines, is one of the rare conditions that come to the minds of clinicians less frequently and that significantly increases the mortality and morbidity if it's not diagnosed in the early period. Spontaneous isolated superior mesenteric artery dissection is a very rare condition without an underlying iatrogenic or traumatic cause. Since early diagnosis will change the treatment method, the time it takes for the patient to apply to the emergency department and the time of diagnosis in the emergency room are very important. Here we will examine a case with the spontaneous isolated superior mesenteric artery dissection and thrombosis. According to the anamnesis taken from a 47-year-old male patient who applied to the emergency department with sudden abdominal pain that started 4 hours ago. His current pain started suddenly, and he applied to the emergency department due to its increasing severity. There was no feature in the patient's medical history other than hypertension and therefore 8 milligram benidipine hydrochloride usage. In physical examination, his general condition was moderate. He was conscious, cooperative, oriented. Vital signs were blood pressure, arterial blood pressure was, and they all in the normal scale. An abdominal examination revealed tenderness and rebound in all 4 quadrants. No pathological findings were found in other system examinations. The patient's history and physical examination findings were evaluated as acute abdomen and symptomatic treatment was started and tests were requested. Laboratory test shows leukocytes were determined as 9,000 millimeter cube. His CRP was 9.8 milligram per liter. Lactate was 1.6. In the repeated examination of the patient, as the abdominal findings increased, intravenous contrast enhanced abdominal computed tomography was performed as an advanced imaging method, and the thrombosed dissection line was detected along the long segment of the superior mesenteric artery, causing partial obstruction. Interventional radiology was consulted for endovascular stenting within the current findings. However, since the procedure was not considered, he was admitted to the general surgery clinic for follow-up and treatment. The patient was discharged with full recovery on the 4th day of hospitalization. Spontaneous dissection of isolated superior mesenteric artery is a rare condition, while connective tissue disorders may be the underlying cause of this disease, which is more common in young men in the 4th and 5th decades. Definitive evidence for the disease is still lacking. In this case, no additional risk factor other than hypertension was found. Although treatment varies depending on the nature of the case, it may include medical treatment such as anticoagulation or antiplatelet therapy or invasive interventions such as endovascular stenting and also open surgery. Due to the emergency department crowd, the time allocated per patient is not sufficient. Appropriate imaging methods used together within the patient's history and physical examination are effective in reaching the correct diagnosis. Thank you. Any questions, any additions?
Thank you very much. Any question, any comment? Thank you.
Thanks.
Next presentation, please. Pulmonary artery dissection in young patient with pulmonary hypertension. Dr. Elif Çamcı, please.
Good morning, everyone. I'm Dr. Elif Çamcı from Namık Kemal University Medical Faculty Hospital, Emergency Department, and I'll tell a case report to you. Pulmonary artery dissection in a young patient with pulmonary hypertension. Geçemiyorum. Nasıl geçeceğim? Tamam. Pulmonary artery dissection is an extremely rare but highly fatal condition. It is first described in 1842, and due to high fatality rates, most diagnoses are made from autopsies. Most patients die suddenly from major bleeding or tamponade caused by direct rupture into mediastinum or retrograde into the pericardial sac. We all know that aortic dissection may develop a reentry site, and this gives us more time to treat the patient and to diagnose patient than treat patient. But unlike aortic dissection, pulmonary artery dissection progresses rapidly and typically ruptures rather than developing a reentry site, and this causes cardiogenic shock or sudden death. It's usually paired with a pulmonary arterial aneurysm, mostly due to pulmonary hypertension. And by telling this case, I aim to raise awareness about this life-threatening condition, besides other emerging chest pain and back pain-related pathologies. When we see a patient with chest pain or back pain, we think of acute coronary syndromes, aortic dissection, pulmonary embolism, but not pulmonary artery dissection, mostly. Our patient is a 37 years old woman. Her main complaint was cold and chest pain and back pain for 2 days. She and her husband, they stated that they were having similar symptoms due to common cold for several days, including a sore throat. Her chest pain was in a stubborn pattern and it was increasing while breathing. Her past history is remarkable, with pulmonary arterial hypertension for 8 years, which treated with bosentan and tadalafil. Physical examination showed a normal oropharynx, decreased lung sounds in left base, and in her back there were ecchymosis due to her cupping therapy. For her cold, she didn't go to hospital firstly, she didn't go to an ED firstly, but she preferred to do a cupping therapy first. And we thought that her back pain was about this cupping therapy firstly. Her blood pressure was 85/50, which responded well to a normal sudden infusion. And her heart rate was in upper limit, and oxygen saturation was 92%, and our patient refused to give an arterial blood gas sample because she said it's painful and she didn't want. Her ECG, we see T-wave inversions in leads V1 to V4 and V3 and AVF, and we monitor cardiacally our patient and take her to observation ward. Her CRP level was 76, and cardiac troponins were within normal limits. We planned a chest X-ray. And after NR challenge, we persuaded the patient to give an arterial blood gas sample. We need that for diagnosis. And we had a problem there. Our ED was extremely crowded that day, and this patient waited more than an hour for a chest X-ray. Arterial blood gas was cancelled with respiratory alkalosis. Also, I thought that it was unlikely in a patient with pulmonary hypertension to see an pulmonary embolism, but this makes us think about pulmonary embolism in ED. So, not to lose any more time, I cancelled the chest X-ray, and for further evaluation, we planned a pulmonary artery CT angiography. And this is our CT's first scan. We see an enlarged mediastinum here. And we see a giant enlarged pulmonary artery about 10 centimeters in diameter. And there is an 17 millimeters length dissection site. And we see an enlarged right pulmonary artery approximately 5 centimeters. And here our patient's sagittal view, our enlarged pulmonary trunk. Emergent cardiovascular surgery and cardiology consultations are made. Her echo was about normal, but also her echo was normal, unfortunately our patient suffered a sudden cardiac arrest while under observation in the ED. After 45 minutes CPR, our patient accepted died. When we see literature reviews, it's first described in 1842 and till 2018 a review of 150 patients shows that the survival rates are really increased till it's first described. And this review showed us that pulmonary artery dissection is not as rare nor as fatal as believed, and with a high index of suspicion and appropriate investigations and early diagnosis of PAD can be made and successful treatment instituted. First, we should suspect of this diagnosis and appropriate investigations should be made. I tell this case to increase pulmonary artery dissection awareness among doctors. This was my first case in a pulmonary artery dissection, and maybe I will not see in my life again this. There wasn't even a sentence in Tintinalli emergency textbook. And symptom awareness among patients should be increased because our patient waited for 2 long days before coming to ED, and we lost time in this crowded ED. Also, when we diagnose these patients, our job isn't finished. We should refer these patients to centers which correct treatments can be made. Thank you for your considerations.
Thank you, Dr. Çamcı. Any question? Any comment? Thank you very much. Bullous skin disease is occurring due to bed bug bite case report. Dr. Abdurrahman Yılmaz, please.
Good morning, everybody. I will present a case report, bullous skin disease occurring due to bed bug bite. Bed bug bites are arthropod bites that are commonly seen especially in developing countries and in countries with low socioeconomic status. If an allergic reaction occurs due to these bites, urticarial skin rashes, macular and papular lesions can be observed. Its etiology is not clearly known. The aim of this case study to present skin reactions observed in a 40-year-old male patient who came to our emergency service due to a bed bug bite. Cymex lectularis, popularly known as the bed bug, belongs to the Simistae insect family. They feed with the blood of human and animals. A single symptom of bed bug bites for individuals who have not been bitten before can be ictioerythematous macules. This case report presents the skin reactions in a patient who has been bitten by a bed bug previously and has presented with the same complaint again. It also details the management of this reaction using corticosteroid treatment. A 40-year-old male patient presented to our emergency service complaining of bullous and papular skin lesions persisting for nearly a week. During the physical examination, it was observed that the patient had healed ulcerated lesions and fluid retention around his left eye. The patient reported that his symptoms arose after contact with Cymex lectularis, commonly known as a bed bug. Upon arrival, the patient's vitals were stable. The patient's lesions are depicted below. We got permission from the patient, and this photograph is taken. These are skin lesions of the patient. And there is a ödem in his left eye. We learned that the patient doesn't have any chronic disease. Other system examinations of the patient were normal. We evaluated for prednisone, pantoprazole, and phenylmelat to this patient. This treatment continued for 3 days. Simultaneously, the patient was prescribed meperamine maleate, lidocaine, hydrochloride, and gel consisting dexpantanol and antihistamine. The change the patient lesions were second day as the picture. Bed bug bites can cause allergic reactions. In this case, both we studied the diagnosis and treatment process of patients who present to emergency service with complaints of ictibulous papular lesions. The patient didn't have any previously known dermatological disease. Patient lesions occurred as a result of bed bug bite. Following our treatment, the patient fully treated and discharged from the hospital. Upon reviewing medical literature, they discovered that bullous reactions from these bites occurred to 6% of the patients. Antigens in the bed bug saliva and responsible for this hypersensitive reaction. Robin and colleagues emphasized in their study that bed bites should be considered during differential diagnosis. These bites, which can cause various skin lesions and physiological disorders, may even lead to anaphylaxis. They also suggest that corticosteroids and symptomatic drugs can be used to combat the effects of bed bug bites. However, the primary treatment is the eradication of these pests. Alexandra and her team report that their study that bed bug bites can resemble bullous disease such as pemphigoid or Dunning disease. They note that differential diagnosis of this autoimmune disease can be accurately made using immunofluorescence examinations. As a result, medical professionals should inquire about potential bed bug-related issues when patients present to the emergency department with erythematous, bullous, or papular lesions. This concern should not be overlooked. Conflicts of... Okay. It's the end of that. Any questions?
Thank you.
Thank you.
Any question? Comment? Thank you. Next. Attitudes and behaviors of emergency department physician towards prescribing oral anticoagulants and the discharge of patient with newly detected atrial fibrillation in the emergency department. Profesör Doktor Görkem Alper Solakoğlu.
Good morning, everyone. I am Murat Metin from Istanbul, Professor Dr. Süleyman Yalçın City Hospital. I'll talk about attitudes and behaviors of emergency department physicians towards prescribing oral anticoagulants at the discharge of patients with newly detected atrial fibrillation in the emergency department. As everybody knows, atrial fibrillation is the most common cardiac arrhythmia diagnosed in emergency departments. All clinical guidelines strongly recommend oral anticoagulant prophylaxis to prevent stroke in atrial fibrillation patients. However, only 20% to 60% of these patients at high risk of stroke are prescribed oral anticoagulant medication. More than one-third of emergency department patients diagnosed with newly detected atrial fibrillation do not see a doctor within 30 days, delaying potentially life-saving treatment, as like stroke. We wanted to learn to what extent emergency physicians use the guidelines in patients diagnosed with atrial fibrillation, their attitudes towards assessing the risk of stroke and preventing it, factors affecting patient approach, how often they use oral anticoagulant drugs, their hesitations and thoughts about prescribing oral anticoagulant drugs. Our study is a qualitative study using semi-structured interviews with the participation of emergency room physicians working at an urban tertiary care academic hospital with an average annual emergency department volume of 250,000 patients. The study group of the research consists of 6 emergency medicine specialists and 20 emergency medicine assistants working in the emergency department. Participating doctors were asked open-ended questions related to the subject of the study. Attitudes towards management of patients with atrial fibrillation in the emergency department, thrombophylactic approach at discharge of patients with atrial fibrillation, physicians' opinions and recommendations regarding the diagnosis, treatment and follow-up of patients with atrial fibrillation. When asked about the practices of emergency physicians regarding the evaluation of patients diagnosed with atrial fibrillation, one of the most frequent answers given by the participants was to seek the opinion of a cardiologist. The participants expressed a common opinion that the treatment and follow-up of chronic diseases should be carried out by the relevant branch physician. These are findings. When asked what the known sources are for treatment decisions in atrial fibrillation patients, the majority of participants answered Chaswas score. However, when asked what is the reason for not calculating the scoring in practical practice, they cited the reason for receiving treatment recommendations through consultation for all patients diagnosed with atrial fibrillation. Although this situation suggests that the level of knowledge of doctors is sufficient, it also reveals the difference in behavior due to the defensive medical approach. Although emergency physicians can mostly manage hemodynamic evaluation and rate control alone in the first intervention of a patient diagnosed with atrial fibrillation, it was concluded that the reason for applying for cardiology consultation was the concern that newly diagnosed atrial fibrillation patients would not be able to undergo outpatient follow-up if oral anticoagulants were started. Emergency department physicians who participated in our study stated that they did not prescribe new oral anticoagulants. As a matter of fact, some participants responded to the questions examining the frequency of new drugs prescribing. He responded as follows: "My level of knowledge and experience about new drugs is lacking." Some emergency physicians have stated that they do not prefer new drugs which are not reimbursed by insurance if prescribed by emergency physicians in Turkey due to their cost to the patient. There are multiple variables that influence emergency physicians' decision to make prescribed oral anticoagulant medications at the discharge of newly detected atrial fibrillation patients. Guidelines specific to the branch of emergency medicine making recommendations for anticoagulants to be used in the discharge of atrial fibrillation patients will reduce the differences in approach between emergency medicine physicians. In summary, the role of emergency physicians in the approach to patients diagnosed with atrial fibrillation should be defined more clearly. There is a need for comprehensive development that includes improvements at the system level, establishing a diagnosis, intervention, prescription, follow-up chain, and increasing doctor training. Thank you for listening.
Thank you very much. Any question? Thank you, please. Comparison of demographic characteristics of unvaccinated patients admitted to give COVID PCR test. Dr. Mert Güven.
Good morning, everyone. I am Dr. Mert Güven from Süleyman Yalçın City Hospital from Istanbul. I'm going to talk about comparison of demographic characteristics of unvaccinated patients admitted to give COVID PCR test. Nasıl ilerliyoruz? In this study, we aim to determine the reasons for vaccine refusal, to compare the demographic characteristics, to learn the source of information about the vaccine in the people who refused the COVID vaccination. In the study, demographic data, we looked for age, gender, education status, occupational status, chronic disease data were collected. In the questionnaire, reasons for vaccine refusal, source for information about vaccines, the number of the PCR tests performed in the last 1 year. In the findings, men are more likely to have COVID than women. The rate of undecided to vaccine among men is higher than among women. Women are more likely to learn about vaccination from medical publications than men. Men are more likely to learn from social media than women. High school graduates get information about vaccination from their environment and television. Primary school graduates show no interest in medical publications. Social media is effective among the more educated people. High school graduates tend to give more tests. Middle-aged and elder are more likely to learn vaccination information from TV and than youngs. Youngs have a higher rate of learning from social media than mid-aged peoples. Mid-aged are more likely to have 2 or 5 tests than those aged youngs and elders. In the discussion, increased educational attainment suggests an increase in skepticism toward vaccines. They have to access more resources, exposed to more misinformation. We found that men and young people had a higher rate of COVID vaccine refusal. Individuals who accepted the COVID-19 vaccine were not included in the study, so no comparison could be made with this group. The reason for COVID vaccine refusal are concerns about vaccine side effects, doubts about the protection of the vaccine, lack of sufficient studies. It is thought that social media platforms, which are frequently used to obtain information about vaccines, may increase misinformation about vaccination and to lead to vaccine refusal. Thank you.
Thank you. Any question? Thank you. Hematoma in the psoas region secondary to trauma and subsequent renal failure. Dr. Mustafa Yorgancıoğlu.
Good morning, everyone. I am talking about hematoma in the psoas region secondary to trauma and subsequent renal failure. Hematoma in the psoas muscle may occur spontaneously or secondary to trauma. Spontaneous causes include coagulopathies, anticoagulant use, and leakage from abdominal aortic aneurysm. While the incidence of spontaneous iliopsoas hematoma is 0.1% in general population, this value is 0.6% in the adult population with the effect of anticoagulant use. Traumatic psoas hematoma may be an indicator of serious mechanism of injury, but may also be a marker of severe blood loss. Case report, a 49-year-old man with non-alcohol-related cirrhosis presented to emergency department with complaints of right lower quadrant abdominal pain and anorexia. 10 days ago, while sitting in a chair, he fell on his right side. vital parameters, we can see hypotensive, the others are normal. Examination, neurological is normal, results are heard in both lungs, peritibial edema are positive in 2 legs, tenderness in the right lower quadrant of abdomen, the abdomen appears distended, there is 6 or 7 cm diameter ecchymotic area extended laterally on the right hip, which turn green in color. Tomography, abdominal tomography relevated 10x8 cm hypodense lesion in the right muscle, psoas muscle. Psoas hematoma due to trauma caused renal failure and anemia. Erythrocyte suspension was given in the emergency room. Urine output was measured as approximately 100 cc in 6 hours. He was then admitted to in the intensive care unit, and it was decided to connect his to the dialysis unit. We can see laboratory result. Hemoglobin is 5.1 birim, and we can see creatine. Also, we use hypodense lesion. Result and conclusion, traumatic psoas hematoma is more common in adolescents. After trauma, pain in the lower abdomen, gait disturbances, motor and sensory deficits in the areas innervated by the femoral nerve may be encountered. A significant decrease was observed in our patient's hemoglobin value compared to normal. In a study by Amar et al., it was reported that hemoglobin decrease was detected in 56% of cases. Cavalier et al., that hemoglobin were attributed to the fact that the psoas muscle have a volume of fluid 10 times its own size. Although surgical methods are preferred in some patients, non-operative treatment methods are preferred in our patient in many cases. He was discharged after his clinical condition. Thank you.
Thank you. Any question? Thank you. Next, please. Factors affecting self-efficacy, self-competence, and willingness of medical disaster. Dr. Görkem Alper Solakoğlu. Sorry, Dr. Nuray. Okay, please.
Merhaba. Hocam, izninizle Türkçe sorsam olur mu?
Sıkıntı yok.
Teşekkürler. Merhaba arkadaşlar, ben Doktor Nuray. Süleyman Şehir Hastanesi'nin acil tıp departmanındayım. Size tıp öğrencilerinin afiyetlerde kendi ve isteklerini etkileyen faktörler üzerine bir çalışmadan bahsedeyim. İçerik bu şekilde. Kısaca materyal metotlardan bahsedip çözümle tamamlamayı düşünüyorum. Çalışanların afet yönetiminde çok önemli bir rol oynamaktadır ve acil kararlar önemli bir etkiye sahiptir. Ancak afet yönetiminin yönetim eğitiminin yetersiz olduğu ülkelerde tıp eğitimi almış olanları etkili bir şekilde yönetmek için gerekli uzmanlık, bilgi ve hazırlık olmayabilir ve bu durumda daha da kötüleşmesine neden olabilir durumun. Öğrencilerin afet müdahalesine potansiyel katkısı literatürde özellikle bu zamanda tartışılmıştır. Türkiye gibi hastanelerin sıklıkla aşırı kalabalık olduğu ülkelerde özellikle genellikle hastaneleri sebebiyle tıp öğrencileri değerli destekleri sağlayabilirler. Aslında yeterli bir eğitim parçası olabilirler. Ancak tıp fakültelerinde çok asgari düzeyde bir eğitim verildiği için öğrenciler bu tür rolleri yetkin bir şekilde yöneten bilgiye sahip olmayabiliyor. Avrupa Birliği İnsani Yardım ve Sivil Kurumlarından finanse edilen TİM projesi ekipleri için operasyonel eğitimi, pilot uygulama ve değerlendirmeye odaklanan standart uygun maliyetli bir eğitim paketi geliştirmeyi amaçlıyor. 2022 tarihleri arasında da Türkiye'de gerçekleştirilen o çalışmada tıp öğrencileri afet fonksiyonel üstü tatbikatları rol oyuncusu kolaylaştırdı ve gözlemci olarak katıldı. Bu çalışmalarda tıp öğrencilere müdahale etme istekli tıp öğrencilerinin atanmayı tercih ettiği rolleri ve Teams projesine katılımcı olmak üzere karar vermelerini etkileyen değerlendirmeyi amaçlıyorum. Üniversitede 5. ve 6. lisans öğrencilerinin afet müdahalesine ilişkin ve tutumlarını değerlendirmek amacıyla kesitsel ankete dayalı bir çalışma. Bu çalışmada öğrencilerin afet yardım çalışmalarına katılmaya hazırladıkları öz değerlendirmelerine yönelik 15 soru hazırlanırken farklı afet senaryolarında da gönüllülük etkileyen faktörleri değerlendiren 25 alındı. Ayrıca afet anında gönüllü olarak istedikleri hastane bölümleri ve kendilerini yetkin olarak algıladıkları alanı tercihleri araştırdık. 71 erkek, 101 kadın olmak üzere 172 kişi katıldı. Ortalama yaşı 23, 21 arasında toplam katılımcıların 55'i 5. 117'si 6. dönem. Bu tabloda tıp öğrencilerin afet müdahalesinde öz detaylı faktörleri görüyoruz. Bu faktörler arasında bu projelerden sonra felaketin görece hasarı tedbirim artık, yaraları doğru hızlı bir şekilde değerlendirebilirim gibi sonuçların daha fazla olduğunu fark ettik. Bu tabloda da tıp öğrencisi afet müdahalesinde istekli faktörler var. Eğer ailem güvende olur, iletişim hattım olursa ya da halinde çalışırsak, amirimle birlikte çalışırsam ya da bu için bana para verir, afet yönetimine katılabilirim gibi sonuçlar elde ettik. Afetlerde öğrencilerin tercih etmelerini etkileyen var. Sonuç olarak bu tablodan çıkaracağımız Teams projesine katılanlar travma bakımı ve ilaç enjeksiyon uygulamasında eğitim almayanlara göre kendilerini daha etkin hissediyorlar. Afet eğitim alan triyaj, travma bakımı, ilaç enjeksiyon uygulaması, hasta takip ve psikolojik destek konularında kendilerini daha etkin hissediyor. Erkekler yoğun bakım konusunda hissederken 6. dönem öğrenciler ise travma bakımı, psikolojik toplum sağlığı hizmeti ve halk ilişkilerinde kendilerini daha etkin hissettiklerini gördük. Triyaj, hasta takip, sağlık konularında kendini yetkin hisseden öğrenciler triyajda çalışmayı tercih ediyor. Travma bakımı ve ilaç konusunda kendini yetkin hissedenler aciz, travma bakımı konusunda kendini kişiler ise ambulansla çalışmayı tercih ediyorlar. Daha çok çalışmamız öğrenci çalışmalarına katılmayı isteklerini ancak motivasyonu artırmak için kendilerini tıbbi olarak hazır hissetmeleri gerektiğini gösterdi. Afet eğitim programlarına stajyer veya rol aktif katılmanın eğitim ortamının bile öğrencilere kendilerini yetkin hissettiği motivasyonlarının arttırdığını fark ettik. Teşekkürler.
Teşekkür ederiz. Diagnosis of diffuse neurology by ultrasonography. Dr. İsmail Erkan Aydın.
Good morning, everyone. My name is Ismail Erkan Aydın. I would like to present a case diagnosed diffuse pulmonary hemorrhage by ultrasonography. Acute dyspnea is a common case of admission to emergency department for survival of the rapid diagnosis and management of the emergency physicians are necessary. Thoracic is widely used in emergency departments in patients with respiratory symptoms, patients. Especially in the last 10 years, the use of point-of-care ultrasound focus has become with increasing focus trainings. In this case, a patient with complaints of breath and rash on body and diagnosed with diffuse pulmonary hemorrhage by bedside focus in ED. A 72-year-old patient was admitted to emergency with a complaint of rash all over his body and shortness of breath. The petechial rashes body, bleeding in the mouth, gums, dyspnea and tachypnea. The tracheal intubation was applied with clinical findings and severe arterial blood gas. It was observed that there was bleeding towards the endotracheal tube. Continuous blood flow was observed when the tube was aspirated. Pressure mechanical ventilation support started. Bedside focus was performed by emergency physician. Focus revealed multiple and lines, pleural abnormality, disappearance, A-lines, subpleural hypoechoic area, hepatization, shared sign, and pleural effusion, predominantly third, fourth, and fifth zones of the right lung, and third and fourth zones of left lung. This image shows multiple and confluent B lines, pleural line abnormality, and disappearance of A line. This figure shows hepatization and shared sign. And this image shows subpleural hypoechoic area. And also, stratosphere signs were detected in M mode in zones with pleural line abnormality, subpleural hypoechoic area, hepatization, and shared sign. The patient was diagnosed with diffuse pulmonary hemorrhage with focus and clinical findings. This image shows hepatization, shared sign, and stratosphere sign, and also M mode. This is our focus exam form, right lung and also left lung. Some pathological signs in this table. In conclusion, the most immediate life-threatening complication of diffuse pulmonary hemorrhage is acute hypoxemic respiratory failure, and its mortality rate is high. Chest X-ray and CT are limited value in differentiating diffuse alveolar hemorrhage from infection or other causes of diffuse alveolar opacification in diffuse pulmonary hemorrhage. Focus contributes to the diagnosis and correct management of the patient in the emergency department in a short time. Thank you for listening.
Thank you. Thank you very much. Please, next. Comparison of pre-COVID-19, COVID-19, and post-COVID-19 urinalysis parameters and assessment of their relationship with renal function. Dr. Leyla Öztürk Sönmez, please.
Thank you. Good morning. I'll talk about comparison of pre-COVID, COVID, and post-COVID urinalysis parameters and assessment of their relationships with renal functions. In this study, we aim to compare the before the disease, during the disease, and after recovery, post-disease periods of the patients in terms of urinalysis parameters and assess the relationship between the changes in these parameters and renal functions. In the study, we evaluated 482 moderate and severe COVID patients who had the data of urinalysis performed in the pre-COVID period at most 3 months before the onset of the disease, during COVID disease, and 15 days after they completely recovered from the disease were included. Parameters of bilirubin, erythrocyte, leukocyte, protein, glucose, STT, and density were analyzed in urines and the results were recorded. In the study, underlying chronic diseases such as hypertension, diabetes, chronic heart failure, patients with urinary system oncological or stone disease, mild COVID patients who did not require hospitalization, or critically ill COVID patients who required intensive care unit follow-ups are excluded in the study. Due to our results, CRP, eGFR, fibrinogen, and D-dimer values were found to be significantly different between the 3 groups. A negative correlation was found between eGFR and both CRP and D-dimer values of the patients during the disease. Urine pH, acidity, presence of leukocyturia, presence of microscopic hematuria, and presence of proteinuria were found to be significantly different between the 3 groups. It was determined that these 4 parameters increased significantly during the disease period and decreased in the recovery period. A negative correlation between urine density and eGFR or positive correlation between urine density and CRP were detected during the disease. Here are the tables of results. The details of pre-disease, during the disease, and post-disease demographical and hematological parameters are shown. And urinalysis parameters tables are seen in the table. The figure of negative correlation between the eGFR and CRP and D-dimer values during the COVID disease, and the negative correlation figure between urine density and eGFR, and positive correlation between urine density and CRP figure during the disease. There are current studies conducted through the comparison of the SARS-CoV-2 positive and negative patients, but our study stands unique as it shows the changes in urine biochemistry in patients before the diagnosis of the disease, during the disease, and after recovery. In literature, Leo reported a higher urine protein pH values and erythrocyte counts, but lower urine density in the COVID period group compared to the control group. Margot detected a higher rate of hematuria and proteinuria in COVID patients compared to the healthy controls. Demirelli categorized COVID patients based on the severity of the disease, and respective percentages of these patients had glucosuria, proteinuria, urobilinogen positivity, leukocyturia, and hematuria. In our study, patients were detected a significant increase in the rates of proteinuria, hematuria, and leukocyte counts during the disease compared to the pre-disease period, and a significant decrease in these parameters after the recovery from the disease. To conclude, the significant presence of hematuria and proteinuria during the disease in line with the literature supports the opinion that the disease causes renal involvement, and the tendency of the parameters on the post-COVID 15th day to return to normal ranges shows us that the effects of the inflammation are reversible after the recovery from the disease. Thank you.
Thank you very much. Next, the last presentation, I think. The DVT developing after a backache, a case report. Dr. Yasemin Pishkin, please.
Good morning, everyone. My name is Yasemin. I'm gonna more one or more the components of the virtual threats, hydrocoagulability, and the annual incidence 5 or transfers per 100. Most the defense nervous system, extremities, case symptoms such as they matter difference in the extremities in the acute phase of the disease. The cases of venous thrombosis can be divided into two groups, hereditary and acute. Immobility is facilitating the development of deep venous thrombosis, and included anticoagulant thrombolysis and in this article, we describe a case of our who remained for 2 days after lower back pain and in the leg and was diagnosed with DEV. A 35-year-old male patient was admitted to the emergency room with complaint of pain and swelling in the leg. The patient had been pain for 1 week. He has watery movement for the left pain and swelling in the left leg for 2 days. He has a cervical disc herniation. His medical history. There is no family history of predisposition of thrombosis. There is no thrombosis. Physical examination, there was in diameter in the left leg compared to the there was an increase in and Holmes positivity was detected in the extremity. Periodic pulses are called hollow. Neurological examination, there is no motor sense. Glasgow Coma scale in 4-line motor power normal. Urinary or fecal incontinence, no fit pathological reflex. Abdominal examination is comfortable, no rebound detected. Tests show no abnormalities in BP and hemogram, dimer high, RP little bit high detected. The other ultrasound was common patient with the preliminary of and thrombosis. Doppler ultrasound revealed that with space thrombosis compatible with and thrombosis which filled the lumen of the left femoral vein, of the tailvein, and it didn't allow flow operation. The patient was consulted to cardiovascular surgeon, detected of deep vein thrombosis. The patient was admitted to planning thrombectomy. Thrombosis and stenosis in people, even people who are not prone to clotting, in patients with lung hernia, tardive prophylactic low rate heparin may to protect against deep vein thrombosis immobilization. It should be kept in mind that patients to deep vein thrombosis immobilization such as lumbar hernia, patients should be advised to remain sedentary. Thank you for listening.
Thank you very much. Oral presentation. All control.
Good morning. Moreno, and from the U.S., Professor Dr. David Carr, Canada, with our moderators. We're going to He is an assistant professor at the All Institute of Sciences in Nagpur, India. Dr. Aj speak to us introduce Wacem.
Trained medicine from as an assistant from